All right, folks, why don't we go ahead and march forward. So next up, we have Doctors Jenny Guyther and Ben Launer. They're going to do an EMS tag team discussion. So Jenny was a graduate of our combined emergency medicine pediatrics program in 2013. Ben was a graduate of the emergency medicine program in 2010 and stuck around for 7 or 8 different fellowships. And we're glad to keep him. And he has returned from Pennsylvania back home. And so they're going to spend some time talking about the EMS response to COVID. And so I guess, Jenny, are you starting out? If so, please go right ahead.
All right.
Great.
Thank you guys. Sorry.
Is your audio on your computer? If it is, can you just turn it off? Oh my gosh.
There you go. Sorry, I couldn't find myself on there. But thank you guys for letting us have this opportunity to do it. As most of you know, Ben and I are both very involved in pretty much every aspect of EMS that you can get into within the state. So I'm going to start and just share some of the things that Baltimore City is doing in terms of EMS, because I think it's really cool. If I can work the computer. There you go. So in addition to the regular operations that already has a very taxed system where, if you remember from working here or are currently here, there's ambulances stacked up and people waiting 40 minutes, an hour for some sort of transport unit to come and get them at a normal standpoint. So when we went into preparing for COVID and preparing for this surge, we had to start thinking about how we were going to do our regular operations and handle the surge to be able to serve the public. So we had to think about the PPE, provider safety, COVID education for both our providers and also what our providers are going out into when they have to deal with the public, deal with contact tracing for when our providers became positive, surge planning in terms of staffing additional units. So if you've noticed here, we actually partnered with Heart to Heart to provide 16 BLS level units around the city. And so you've seen some of them probably coming in, and it's a little bit different for a private ambulance company to deal with a gunshot wound on the corner than the typical take them to the nursing home type transport. We've had to interface with pretty much every hospital system, so there's 11 hospitals when I counted them up in my head the other day in Baltimore City, and at least 4 major groups between Maryland, Hopkins, MedStar, and Lightbridge, and all of them have their different policies for how they're handling EMS offloads and the interactions with EMS. And we've had to kind of deal with things from both the hospital side in addition to the provider side. Nursing home interactions have become a huge issue. And then we have an emergency operations center that we have representatives in who help manage the global picture, or the state picture. And then we've been working with regional medical directors at different levels and kind of comparing what's going on in Baltimore County or Howard County or even PG. And so we've had lots and lots of meetings around that. So everybody, even this morning, has kind of been talking about, oh, we haven't seen stubbies, we haven't seen strokes. So I went and pulled kind of some of the data from the city and compared the middle of March to the end of April from this year compared to last year. So our call volumes are definitely down, about 5,000, give or take. But our STEMIs, if you look at the absolute number of STEMIs is exactly the same. But when you break it down by the percentage in relation to the number of calls, we're actually up slightly, 0.17% of our calls. And these are total incidents, include both fire and EMS. So they're not just all EMS responses, but the majority of them are EMS. So STEMI may actually be up a little bit in our pre-hospital data, but I did not calculate a p-value. Strokes are, I don't know, give or take the same. Our number is down a little bit from last year. I don't know whether that's clinically significant or not, but our cardiac arrests are definitely up. And these do not include death on arrival. These are only the cardiac arrests where we actually transport the patient to the hospital and those that we use the termination of resuscitation protocol on. What I didn't show up here was that the absolute number of termination of resuscitations for this year compared to the same time frame last year are up significantly as well. And I'm fairly confident that 2.62% versus 1.97% is going to wind up being statistically significant. All right, so there's 2 really exciting protocols that I'm going to talk to you all about, and then I'll let Ben take over. But the state was able to come up back in when we had the 2009 H1n1 pandemic. They started thinking about a pandemic protocol, and to my knowledge, it was never enacted. But this year, they decided to release this protocol that was optional to the jurisdiction, and the city decided, well, if we can use this protocol, enact it correctly, so where we can maybe keep some of these people home who are having influenza-like symptoms or what turns out to be coronavirus-like symptoms. So when an EMS crew gets to the scene, what they do is if the people check yes for the non-shaded boxes, which can be a little confusing, and meets all of these criteria, one of which is patient is agreeable to home care, then they can actually recommend that the patient stay home, and they give them discharge instructions kind of similar to what we have from the hospital when you're discharging somebody, and then they don't have to be transported at all. And that's a big step in terms of the kind of you call, we haul mentality for a lot of EMS, so it gives our clinicians a little bit of flexibility there. So far, since March 17th, which is when we started this, as of last Friday, we had used it 184 times. Now, the caveat is that number comes from the amount of times the clinician actually checks the box on their PCR that says, I use the ILI viral syndrome protocol, which may or may not be perfect. And of those uses, we had 41 that actually stayed home. We do 100% quality assurance on these calls. So at 24-hour follow-up, they get a phone call. We make sure they're not dead or anything like that. And only 2 of them had gone to the emergency department out of those 41 that we advised to stay home. And everybody else seems to be doing okay, which is wonderful. The other amazing thing about this protocol is normally with the city, it takes us 6 to 9 months to fully educate the entire department, 4 shifts plus an E shift, that's a day-to-day shift. We trained 1,000+ providers in the city in 4 days on this protocol, which I don't know how we did it, and our training staff did an excellent job. So definitely very difficult. The other thing that is really cool is we started a telephone triage line. And basically, when you call 911, the 911 dispatcher answers. They rely on dispatch type calls and dispatch codes, and you get sorted into anywhere from an Omega response, which is the lowest acuity, up to an Echo response. So the Omega calls, I have a ring stuck on my finger and I can't get it off, and there's no like vascular compromise or anything like that. I'm pregnant and my water broke, but I'm not having contractions and I'm full term. Those are examples of Omega calls. Alpha calls are also lower acuity. The sick card falls under that. This is also like I had sunburn, or I stubbed my toe, or I've had abdominal pain for 18 years and it hasn't changed. And then you have above that, Bravo through Echo. Echo would be your cardiac arrest, your non-breathing type patient. One of the ideas is that if we can take the Omega and Alpha calls out of the EMS system and try to give another resource, we could potentially offload both our EMS responses and the hospital volume. And so we actually used real data to figure out what we were going to do. So this is kind of January through March's Alpha call data, and it's broken down by calls of the days of the week. But you can really see any average day in the city during that time frame we had between 60 and 90, give or take, Alpha level calls. And then this is kind of Alpha and Omega broken down in times of the day, because we needed to figure out when are we going to staff and with who we were going to staff this theoretical telephone line. And so 9 to 9 seem to be kind of some of the peak hours for EMS. And so then what we had to do is look at the actual calls that were coming into the 911 system and make our own call. So once 911 screened out, okay, this is going to be an Alpha or an Omega call, let me send it over to our providers who are answering the phones in the communication center, who are either nurses on the side who have that background or experienced paramedics. When they get the call, what are they going to do? So they have a set of questions that they're going to answer, and we basically went through all the different types of calls. This is just an example of one of them. And based on the characteristics, so they would ask, you know, if I got bit by a spider, do you have any difficulty breathing? Did you have a bee sting to the mouth? Something like that. They're going to get dispatched ALS. For BLS, you can see just an example of some of those things there. And just so I didn't blind you, I broke it up into 2 screens. Right now, this was a telemedicine section that we're working to implement in the future. So right now, these are getting dispatched as BLS. But what's important is this no response section. So if this bite caused a small laceration, abrasion, or puncture wound, persistent discomfort, itching, swelling, rash, they had a tetanus a long time ago, there was a tick and they didn't remove it, they would then kind of go through a series of other questions with our nurse provider or nurse or paramedic provider, and hopefully we would be able to say, maybe you can call your primary care doctor, maybe you can go to an urgent care center, maybe you can stay at home and see how you do, give that sort of advice in hopes that some of these people would stay home. This is kind of our model that we have, right? You can have 3 options once you get to the kind of paramedic triage. One is your ALS, the other is your BLS, and then no response. Now, if the person says, send me a medic, we're, of course, not going to refuse care to anybody, and they will get some sort of transport unit. And then up there in the corner is just a picture of some of our paramedics taken from Facebook, I know. I can't control the people that were the only one I could find. But these are some of our results, which is awesome. These are up to date as of last Friday. And what it really shows is the reasons that they wind up going to the ED once they get to the access line. So if they don't speak English, we can't really do much. We send the unit. If the doctor told them they needed to go to the hospital, well, they should probably go to the hospital. If they can't access their PCP, if they insist on the ED, broken down there, the NICE number is those that don't get a response at all. And I should say it's not necessarily that they don't get any type of response. A lot of our successes with our new response people is that we've really been able to help out socially. So there was one example of an elderly lady who just needed a medication, and she'd already had a televisit with her primary care doctor who had provided the medication. Medication was sitting in pharmacy, and the only reason she was calling 911 is because she had no way to physically get that prescription. So our provider on the phone was able to actually call the pharmacy and arrange for the pharmacy to deliver the medication to the patient. So everybody was happy in the end. We helped them out, and the patient did not come to the emergency department. We also have 100% QA for this program as well, which for the amount of calls that we normally run is excellent, and we're able to 100% QA both of these programs. And this is what we have on 24-hour callback. No one has died. And the biggest percentage, I go for that a lot sometimes. The majority of them have no change or they feel better. Some are still attempting to contact their primary care doctor. We do at least 3 phone calls in those no answer groups just to make sure. A small percentage have gone to the ED on their own, which they are certainly more than welcome to do, and a lot of times going to the ED by solution is taking a 911 resource for some of those, and we haven't had anybody call back. Sometimes we'll say if you feel worse, call back in a little bit. We haven't had anybody call 911 back again within that 24-hour window. You can see our total numbers down here, which is a little bit easier to read, but of all the calls that came in, we wound up having 23 no responses, and the majority being dispatched BLS and some getting ALS resources. The future directions with this, we're working to try to tie in mobile integrated health, which is kind of starting to come online, and we're looking at eventually tying in alternate destinations. Our treat and release is part of our mobile health, and then ultimately if we get a firmer grasp on telemedicine, maybe we'll be able to incorporate that into some of it as well. I'm going to hand it over to Ben.
All right, thank you. All right. Hey everybody, thanks again for the invitation. We will jump right in. So one of the things I think that you'll see, and I know Dr. Guyther is very modest, to give you an idea of how we're kind of connected to the system. I also provide medical direction for the city. Dr. Guyther wears a couple of hats with the state. I also do the critical care transport piece over here, which is kind of difficult. But one of the things that I hope you're seeing is that EMS really is kind of a misnomer. It's not really emergency medical services. What it is really a system of care. So one of the beauties and frustrations of what it is that we deal with every day is, in addition to the social challenges of health, in terms of what to do with patients who don't have access, we also have to deal with the problem of how to get patients into an academic medical center. And for those of you that are our residents, you know that even when you're in our ED, this can be exceedingly difficult. And EMS, therefore, is both a passion and a beautiful frustration. So I wanted to talk a little bit about that because COVID has literally turned everything upside down. What we used to do, and I know this is a common theme, and it's really great to hear everybody else talk about this, what we used to do, you call, you hope for the best, you match a resource with the appropriate need, has been exceedingly difficult, especially in the time of COVID, because it requires a little bit of restriction. So I wanted to talk a little bit about the critical care transport piece, which is another one of my passions, and it's posed significant challenges, especially as you talk about intubation and triaging people to other modes of ventilation. So we'll talk a little bit about that. I think critical care transport in the COVID era has a couple things. So first of all, we have to talk about what type of services are we doing. Now, it used to be in the initial sort of rollout of this, we talked about that everybody needed to be intubated because that was the safest thing. We put everybody on HEPA filters. You're in a box that's relatively confined. If you're flying in a helicopter, this is a 407, we have a EC-135 helicopter, which is a small little sports car. We don't recirculate the air. And despite the fact that people think you can open the window and, hang your head outside, it is impossible to recirculate air, especially in an environment where you're aerosolizing. So what was pretty much routine, where we used to take pretty much everything, we have now a couple of restrictions. And it's interesting, you're hearing these debates about, well, what do we transport? And it's very difficult to talk about age. Well, what's really interesting about COVID is that we have now been talking about this for quite some time, meaning that patients that are critically ill, that are on multiple pressors, that are on non-invasive ventilation, we now talk about DNR because, as you might imagine, it is very difficult to orchestrate cardiac arrest management if you're either prone, if you're lying on the side, or if you're receiving multiple pressors on Aprv and transport. So we've had to talk about risk benefits now for quite some time, ever since the first COVID transport had actually happened, because we are also interested in making sure that we match the patient population, the right patient at the right time with the right resource. So I totally appreciate what's been going on. I know you heard previous discussions about, well, is it appropriate to bring somebody who may be advanced in age with significant comorbidities who's intubated just because we need an ICU bed? And now that we're exposing additional amount of crew members of people, sometimes that decision is, let's talk about goals of care, maybe that's hospice, let's talk about alternative destinations, or maybe we can't help that patient because it's not in the risk-benefit synthesis, it doesn't represent maybe the most safe option. So in terms of critical care, in terms of what we do non-invasive ventilation, which is high flow. I know Dr. David Gordon will be very pleased to hear that we do Aprv, which is another advanced mode of ventilation for our patients that are intubated with COVID. We also provide Ecmo Cannulation, support for Ecmo Cannulation, patients that are being transported to a referral center where you have a very young patient. The criteria has been, I think, very strict and limiting, but if you have a very young patient with terrible lungs, we will also transport those patients from hospital A to hospital B, and that requires a fairly heavy lift involving respiratory therapists. We all know that they are not just little adults, except for the fact that we are, and that we put them in the same ambulance and we use a similar team, which is great. Because I'd also put in a plug here for transport medicine. Those of you that say, if you feel that your scope of emergency medicine practice is being somehow limited, what is great when you do with the critical care side is that literally, I think my first day that I took over from Dr. Gash, hello if you're out there, Dr. Gash, we literally had a massive transfusion protocol from one hospital with multiple gunshot wounds, because that's what happens in the era of COVID. We took the patient from hospital A to hospital B, chest tubes and thoracic decompression. We also deal with pediatrics. We also transport well neonates. So, interestingly enough, the first COVID transport occurred from an airport. So nobody had known what this was going to entail, but I remember very clearly the first COVID transport for our system happened at a remote location, and so we were still kind of figuring this out. We used 2 ambulances instead of 1, because those of you engaged in EMS know that ambulances sometimes break down, or in the city they may catch on fire. One never knows. So our plan was to take 1 ambulance with the equipment, another one with the crew, because sometimes it's also challenging when you deal with issues of contamination. So we went to the airport to pick up this first patient. This was a patient that was being repatriated from overseas, was in need of advanced ventilatory support, had, I think, at one point in time, a vasopressor requirement, and we consulted with infection prevention and made the determination that the risk outweighs the benefits, because we wanted to match this patient with an appropriate level of care. So we no longer use 2 trucks, because we rapidly found out that ICU beds, COVID is a disease of intensive care availability, especially for the critical care patients. So I think we found out pretty much on hour 2 that this concept of taking 2 trucks to take care of 1 COVID patient was not at all sustainable. And that also posed further challenges to what it is that we do too. So several specific concerns. We, just for the purposes of our transport program, we can prone, but we do not. We do not prone and transport simply because in order to do this in the middle of a pandemic protocol requires a lot of coordination. Plus there's logistics in terms of how do you provide CPR. Currently, we do not provide CPR and we try not to for COVID-positive patients that are intubated. So a couple of things in terms of dangers of aerosolization. We're also seeing some really interesting physiology. So sometimes with patients that are intubated with COVID pneumonia, and I know Dr. Sanavika talked about this earlier, the amount of driving pressures that you need on the ventilators are excessive. So we encountered actually 2 patients who we were not able to ventilate simply because the flow rate and pressures were so high. We actually had to bring a